Dr. Lowell Chambers. I'm a general surgeon with Central Ohio Surgical Associates in Columbus, Ohio area. I'm also the program director of the general surgery residency at Mount Carmel, and I work in the trauma corporation at Mount Carmel as well. You are listening to Interview with the Surgeon Agent.
Hello, everyone, and thank you for joining Interview with the Surgeon. Today, we welcome Dr. Lowell Chambers, Department Chair of Surgery at Mount Carmel. Doc, how are we doing today?
Good. Glad to be with you all.
Thank you for being with us. Getting started, what were your goals and aspirations during your residency?
So, as I went into general surgery residency several decades ago now, my primary goal was to be a solid, broad-based general surgeon. As I got into training, I found that I had a specific interest in a number of areas. Hepatobiliary and pancreatic really appealed to me just from a technical aspect. I really enjoyed surgical critical care as well, such that, because I wanted to be able to continue to be the captain of the ship, if you will, for these severely ill patients after our surgery and stuff, and not necessarily have to depend on others for that. And I also had a significant interest in trauma. So I was fortunate to kind of be training at really the tail end of the era when it was possible to be that broad-based. And so, as I went through my training, and I was very fortunate to be selected into an independent academic medical center that has an excellent surgical training program, did at that time. And I guess I'm a little bit biased because I'm the program director there now, but I'd like to think it still is today. That was able to give me that type of training under Dr. Thomas Hartranft at Mount Carmel in Columbus, Ohio. And so it's pretty hard to do in this day and age, but in that era, I could still come out very well trained in bread and butter general surgery, but also with significant expertise in hepatobiliary, pancreatic, trauma critical care, and surgical critical care as well. And I was able to ultimately augment that some with some time at LA County under Dr. Dimitriades, Dr. Velmahos, Dr. Rhea, and some other internationally recognized leaders in trauma and critical care while I had my time in the Navy. But really, I just wanted to be the absolute best surgeon that I could be, and to take care of patients well, and to be the best surgeon possible. And I think due to a lot of great faculty and some great co-residents and a great training program, I came out after 5 years of training, ready to do that.
To kind of talk about being done with your chief year and then going into that transitional phase to the professional world, knowing that you were in the Navy, what type of pros and cons did you go through, and what did you learn from that experience?
Yeah, so one thing about our program that was really great, and still is great, is that in our chief year we run our own service for the entire year, obviously in accordance with ACGME regulations and under attending supervision, but it's really as you are as autonomous as possible. And so it's really like a mini attending year. So I really came out after my chief year having essentially functioned independently, and that was an extremely a strong point for me, that I was able to go through many of the trials and tribulations that you go through as a young attending surgeon. But number one, I was technically still a resident, and so I always had attending faculty around to ask for help. But also, I was looked at by referrers. I was looked at by the OR and stuff as a resident, and they weren't judging me, frankly, as harshly as they would be as a junior attending. So I came out very well prepared because of the way that Dr. Hartranft and Dr. Richard Zollinger before him had structured our program. And I guess that's one thing I would pass on to the younger folks up and coming as surgeons is, while your program, ours is kind of unique in that regard, and your training program may not offer that good, if you will, of a chief year. Nonetheless, when you start in whatever your first job is, be sure that you're comfortable that you've got partners that are going to be there to back you up, that are going to be there to kind of, for lack of a better term, nurture and support you. You want to have people that you're not intimidated to ask for help, that you don't look at, asking for help as a sign of weakness. I remember going through residency program training, and, I think it's got to do to some degree with just maturity. But I initially looked at not because of any people around me, but just because of my own values, asking for help is a sign of weakness. With several decades under my belt now, I know that that's not the case. Asking for help when you need it for the patient's benefit is actually a sign of wisdom and strength. And make sure, that you're joining a group where your future mentors, your senior partners, have that mentality. You don't want to find yourself in a situation where you don't have that help and that backup. But I was very fortunate, and I came through my chief year having gone through most of that. And then, unlike most of the people who will probably be viewing this, my future was a little bit set for me for the first 4 years. I had obtained a health professions scholarship program, which meant that after my time, and what that essentially means is that the military had paid for my 4 years of medical school. And so I owed them 4 years of payback specifically to the United States Navy. And so as I came out of my general surgery training program in my chief year, I was bound for 4 years of service in the Navy. That ended up coming at a very pivotal time, which I'm thankful for in retrospect. I'm not thankful that it happened, but if it was going to happen, I'm thankful that I was able to be there to make contributions and to help. I graduated the program at Mount Carmel in June of 2021, and I was in Yokosuka, Japan in early August of 2021 as a surgeon there at the local hospital there, I should say at the Navy hospital, and on the aircraft carrier, which was ported there at that time, the USS Kitty Hawk. And shortly after that, the events of 9/11 occurred, and before you knew it, we were swept up in that. And so over the next 4 years, I found myself kind of unexpectedly called upon to perform very high-level trauma care in the austere environment of the combat theater. And I am so thankful, and was so thankful at that time. And as I look back in retrospect, for the outstanding training that I'd received at Mount Carmel, and I was also privileged to spend time at LA County with Peter Ree and Dr. Dimitriades and George Belmahos and others, due to a program that the Navy had at that time called the Navy Trauma Training Center, which was essentially kind of a mini fellowship that our entire team. So they took not just me, but not just the surgeons, but the nurses and the corpsmen and stuff up there, and we helped care for patients as a team before we deployed. And so it was kind of a mini fellowship, but one with the added advantage that I was there with the entire team that I was going to be deployed with. And so those were very eventful and formative years that I came into during my time with the Navy. And as I look back on that, I'm so thankful for many things. One is the leadership and the mentorship of a guy named H.R. Bowman. Captain H.R. Bowman was really the architect of the forward resuscitative surgical system, these small kind of paradigm shifting, small forward combat surgical units that we worked in. And the deployment of these was not without controversy. And, Captain Bowman took a lot of heat, including from some leading authorities in civilian trauma. And as I look back, I didn't really appreciate it, as you often don't when you're around great people. I didn't appreciate really what he was doing, and frankly, how great a man he was and is, until looking back in retrospect. But I can only imagine the pressure that he was under as, all of these units, which we ultimately deployed as the invasion phase of Iraqi freedom, Operation Iraqi Freedom occurred. And this was after I, returned from Japan, and I'd shifted to Camp Pendleton as a home base. But as I look back on that, and the outstanding success that those units were due to his preparation, and to be able to work under him was a great privilege, and the great teams that we had. I do a lot of talks on quality and performance improvement and stuff, and as I look at performance improvement and stuff, it really ultimately fundamentally comes down to one holy grail of discretionary effort. And if those around you and your team members recognize that they're part of something bigger than themselves, that they are able to achieve things as a team that go beyond our individual goals and needs to do a greater good for society. That's extremely powerful, and that's what we had with those teams. And we had great outcomes. So as I look back on those years, I learned so much, from Captain Bowman, just about leadership, and from my teammates that I worked with, about the importance of team as one of the primary things. Going into that, I think as we all are, you have to be confident to be a surgeon, right? I mean, and so I come out of training and I've worked hard, I'm well trained, and frankly, I'm pretty full of myself. But there is few things more than or better than a mass casualty with multiple improvised explosive device, injured and high velocity gunshot wound injured patients to humble you, especially when these are young, heroic, people, and that not just they, but their families are counting on you, a tremendous pressures. But to come through that and to be able to see in retrospect that, we got historically good outcomes. We were part of paradigm shifts in care, establishing one-to-one resuscitation principles with hemorrhagic shock, establishing temporary vascular shunting as a good means of damage control with major vascular trauma, establishment of en route care nursing to help transport patients. This was a lot of historic stuff that we were able to take part of and be part of. But as I look back on that, and as I learned at the time, I'm important as the surgeon, but I was really just part of the team. And this was really driven home to me best by actually the Commandant of the Marine Corps. As our unit really got some outstanding outcomes, we started to be recognized throughout the theater as a unit that was doing a number of things right. And again, I say that not braggadociously, because it was truly a team effort, and I was just a small part of that. But so we had a lot of dignitaries come through in the last month and a half or so there to tour our unit and stuff, kind of see what made us tick and what was working, what wasn't working, so they could export it to other units. And that was pretty cool. But for me, as a former enlisted Marine, the coolest thing was when I learned that I was going to give a briefing to the Commandant of the Marine Corps, the highest. I mean, just a few years previously, I've been at Parris Island as a young PFC, and the Commandant's just a few steps below the President and God, at that point. And so for me to be able to give a briefing to the Commandant, man, that's pretty cool, man. And then when I hear he's going to do an after action report about it, I'm like, oh, that's even cooler. I'm going to get a copy of that. I'm going to send that back to Mom, man, show her just like I used to do my papers in, grade school and stuff when I got good grades. Commandant's going to talk about what a good surgeon, Chambers and his team is and stuff. And as I gave the briefing and get that after action report about 10 days later, which is designed to, export, what they learned and stuff, try to use it for other units. But I'm reading it, I'm like, man, this is going to be good. And he starts out, he said, as a former athlete, I want to break this down into what I think are the MVPs of this outstanding unit. And I'm like, oh man, this is really going to be good. Now, I can see an MVP Chambers, across the, and I start reading it, and he says, well, the most important person here is your generator operator, because our base was getting hit with rocket attacks, our power would get knocked out not infrequently, and it was this young man who had a high school education, and that was it, who would go out and brave the hazards of the incoming fire to get our generators back operating, so we could take care of patients without having to be on. So he said consideration should be given to have one less medical member and an additional generator operator, because if you lose this guy, so in essence he's kind of saying you could do with one less surgeon and get another generator operator. Not exactly what I expected to hear. And then the whole thing just goes on. He talks about the people that were directing the comms and stuff, and the in-route cameras. Didn't mention the surgeons in the entire document. But that was a great message to me, as a young, confident, borderline cocky surgeon, is that absolutely what I do is critical to the team. What I do is important, but I'm just that. I'm a part of the team. And I think it was that recognition that has really enabled me to be much more effective since then than I would have been otherwise. recognizing that it truly is a team, if you want to call it sport. I don't know, some might take offense at the word sport and what we do, but it's a team effort. It's a team effort we have in taking care of patients, and in recognizing that each member of the team is absolutely essential, and in conducting yourself in a fashion that reflects that is really, to me, what effective leadership in surgery is about. And I'm appreciative to the commandant for teaching me that. But so, I came out, and it was pretty intense those first 4.5 years. But those are very formative for me. And so I guess for people coming up, and the younger generations, what I would pass on to you from my experiences is recognize the power of good mentorship. I look at H.R. Bowman and just following his examples of leadership. I look at Thomas Hartranft, who was my program director in residency, who taught me to be a diligent, a good surgeon. In undergrad, I remember a guy named Winston Smith, who was the hardest teacher I ever had, but he was the one who really taught me to trust in God and believe in yourself. I didn't have a lot of confidence in myself. I got this hick accent. I come from a small community, not a lot of doctors out of, our community and stuff. But Winston enabled me to believe in myself. And so, and my parents instilling good work ethic when they're farm, at each point along the way, I look back and I kind of feel like the Lord's provided me with a good mentor at each of those stages, and seek out those people. And learn from them, and seek out, good ones. The second thing is team, just the power of team, and recognizing that while what we do is essential, and while we are called to be leaders of the healthcare team, it is just that, a team, and conduct yourself in such a fashion that lets your teammates know that you recognize their value.
So, what type of are you looking forward to going for interviewing medical students for residency spots and also residents for fellowship spots?
Yeah, so as not everybody's the same, but I think most of us as program directors are looking for a number of core things. On the more superficial aspect, we like athletes, musicians, because those are people who have shown, a certain amount of tactile awareness, coordination. Also, if it's team sports, working together as a team. Personally, I like people who've had real jobs. It just isn't as, and certainly some of my university colleagues might feel differently, but if you have a couple research articles and stuff, to me, that's great. But, tell me you worked at, 5 years at Burger King while you were going through high school, or that you held down a job when you were going through undergraduate, and that you've shown that you know how to work hard. So people that have grown up, working on the farm, or, working in other in construction, things of this nature, that speaks a lot to me. And I think resilience and grit is key. With Angela Duckworth's work on grit about a decade ago now, I think a lot of us have recognized just the value of the core value, really, of grit and resilience to being critical to what we do. And so, we had a young lady who didn't end up matching with us, but years ago, who frankly had lower board scores. But then, as I'm reading her personal statement, this is a young lady who graduated high school, for a while living in a box behind a grocery store after, she was essentially abandoned by her parents and stuff. And so, that type of overcoming spirit and resilience and stuff, that's what we're looking for. But at the end of the day, you also have to be able to pass tests and have the cognitive ability to do what we do. But, I'll take somebody with a board score 220, who's grown up, working hard in team sports, over somebody that has a 250 who hasn't, frankly. And the main thing we're just looking for is team players, and also people who will recognize that the patient, has to come first. Those are hard things to ferret out through interviews and things. I think we're pretty successful with that at Mount Carmel. I think we've got a great team, but it's a difficult task from a program director standpoint. But so some of that's my bias. Some of it I think is fairly universal as far as in the grit and resilience component at least.
So as you know, I've talked to physicians all over the country, and one of the big conversations I have with chief residents and fellows is either going private practice or going the academic route. Can you kind of talk about the hybrid model that you're currently involved with?
Yeah, so I'm with Central Ohio Surgical Associates. That's a private practice general surgery group. It's some of the more senior people are amongst those that trained me. We work in the Mount Carmel health system here, but we are not employed by the Mount Carmel health system. We're independent. I also am privileged to be the program director of the residency, inheriting that from my predecessor, Dr. Hartrana. And I'm also employed by the hospital as a trauma surgeon or in the trauma corporation. For me, I just don't like in this day and age having all of my eggs in one basket, so to speak. Administrators come and go. Some are frankly very malignant, others are more collegial, and you don't necessarily know where you're going someplace, who that administrator may be 3 years down the road. And so I personally am uncomfortable, solely being an employed academic or surgeon or frankly trusting any single administration. So I really like the model where I've got my private practice surgical income, and I also, serve the hospital system in several employed capacities. That just provides me with job security because you want to kind of keep it positive because it's a great privilege to be able to do what I do. And I think although it's different from what it used to be 20 years ago, 30 years ago, medicine is still extremely privileging to be able to practice in. But there are some administrators and institutions out there, they'll cut your throat and not think twice about it and cast you to the wind. And, it's good to have a backup plan or a situation in which you don't have to fear that as much. And ultimately it has the potential to translate to patient care. Just to get real for a minute, there are situations where, let's just take a hypothetical, hey, I've got a post-pancreatic duodenectomy patient who's, struggling a little bit. They're, in their 14th day of admission, let's say, and they've had, unfortunately, some complications. And I'm starting to get letters from the discharge planners, hey, and Dr. Chambers, so-and-so's been here a long time. The DRG's about up. We've got this LTAC. This select facility that could take them, can we go ahead and transfer that patient? And, the level of care just isn't as good there. And so there's that external pressure, to transfer the patient. I like, because although I work within, my system to try to keep costs down as much as possible, the hybrid model allows me to keep my primary allegiance with that of the patient. And so if it's not the right thing for them to be transferred, I'll transfer them. And if I get a call from some high-level administrator that, hey, you may not get this bonus or this may be looked at, disfavorably, so be it. My conscience is clean. I'm doing the right thing for the patient.
We hope you enjoyed this episode of Interview with the Surgeon. Until next time, stay focused and keep following your dreams.